In myelofibrosis, standard practice is to intervene with the JAK inhibitors. Typically, that's ruxolitinib, to control the spleen. Symptomatic splenomegaly is a problem, and to control systemic symptoms like night sweating, low-grade fevers, itching, and others. We also have an issue of anemia, but JAK inhibitors that we currently have are focused on control of the spleen and symptoms. Now, in that sense, we learned that earlier intervention, not waiting for patients to be too sick, makes a difference. It's easier to manage patients that don't have a huge spleen, that don't have already anemia, thrombocytopenia at the time of initiations of JAK inhibitor, because JAK inhibitors can have those side effects, so they may just worsen anemia, thrombocytopenia. And we also have a good evidence that early intervention makes people live longer with the controlled signs and symptoms, which may not be logical. We are not eliminating disease, but we are providing with the JAK inhibitors anti-inflammatory and anti-proliferative effects, and making the spleen as small as possible, for example, eliminating the symptoms, will make these people live longer with the disease. So earlier intervention has multiple benefits for the patients, and I encourage everybody to think about earlier intervention in the management of patients with myelofibrosis. Why wait for patients to be too sick?